Hello, dear students. This is my class on superficial mycosis and dermatophytosis. Superficial mycosis are that group of fungal infections which primarily infect the stratum corneum of skin and suprafollicular portions of the hair. Here, there is very low immune response and therefore very less tissue damage. Most of the patients seek attention only for cosmetic reasons or primarily for cosmetic reasons. There are several superficial fungal infections. Let us deal with them one by one. First, we will discuss about pityriasis versicolor. Versi means variety, color means colors. So as you can see here, the patients with pityriasis versicolor usually have multiple well-defined non-inflammatory macular lesions with fine scaling. They are usually non-pruritic in nature. The lesions can be from hypo to hyperpigmented patches, and they are predominantly located on the exposed part of the body, like your neck, face, upper part of trunk, and upper arms. There is no racial or gender predilection for development of pityriasis versicolor. Even though it is rarely seen in childhood, majority of the patients usually fall under 20 to 45 years of age group. Humidity and increased sweating are known to be the predisposing factors for the development of pityriasis versicolor. Primarily, these varying pigmentations are because of the interference with the melanin production. Depending on the skin color of the individual, the pigmented patches will also vary. Usually, pityriasis versicolor used to be called as gomara or tears of liquid gold in rural Sri Lankan women. In their local vernacular, Gomorrah was considered as a kind of a beauty spot for a woman. The more the beauty spots, the better the prospects for a woman to get married. Pityriasis versicolor is caused by the fungus Malassezia furfur. Malassez means spores without fungal elements, and furfur infers furfuraceous or whitish greasy looking loose flakes. They are usually seen as normal commensal, which are endogenous. Usually Malassezia causes, apart from pityriasis versicolor, it also causes seborrheic dermatitis, atopic dermatitis, dandruff, folliculitis, systemic infections, especially in the immunocompromised individuals who are septicemic or who have pneumonia. They are also known to colonize in the IV lines and the catheters. Seborrheic dermatitis may range from mild to severe forms. What you are seeing is both these extremes. The milder form is known as the common dandruff, where you have your whitish flakes, whitish greasy flakes can be seen. And severe form, we'll see erythema with chronic inflammatory dermatitis. It is usually seen in infants and young adults. Malassezia furfur can be obtained by directly scraping the lesions with flame sterilized number 15 blade, or from the edge of the glass slide, or from the fingernail. Prior to the scraping, the lesions should be sponged with 70% of alcohol to get rid of the skin contaminants or skin commensals. A very characteristic feature of malassezia is that it is lipophilic, in the sense that malassezia is usually seen in sites which are rich in sebaceous glands. This explains the predominance of occurrence of lesions on the exposed part of the body, namely the neck, face, upper part of trunk and upper arms. If we do a KOH or a potassium hydroxide mount, we can appreciate this fungus as having a spaghetti and meatball appearance. Sometimes he also mentioned as banana and grapes appearance. Spaghetti means clusters of yeast cells with short hyphae, and meatballs infer occasional budding that is seen. Culture can be done by inoculating the specimen on Sabrot's dextrose agar with chloramphenicol, and at 37 degrees Celsius we generally see small cream colored yellow colonies with raised irregular edges. The special medium used for culturing malassezia is your modified Dixon agar. Apart from culture, we can also diagnose the malassezia infection by detecting the antibodies and as well as the molecular methods. Generally, we prefer to treat this infection with oral itraconazole for 5 days or fluconazole for 3 days. Topically, we can use shampoo based antifungals with 2% ketoconazole ingredient along with zinc pyrithione. Pityriasis versicolor we specially can be managed with topical Whitfield's ointment and 2.5% selenium sulfide shampoo. The next infection is Tinea nigra. Tinea nigra has got an incubation period of 2 to 7 weeks, usually seen on the soles and palms as circumscribed, solitary 1 to 5 centimeters well defined brown to black macules or coin-sized lesions. They are very rarely seen in neck or chest. The preponderance of the lesions in both soles and palms is directly the result of increased density of the sweat pores. Therefore, in those patients with hyperhidrosis, this particular infection is frequent. It is more increasingly noted among the female gender who are less than 20 years of age. The causative organism of Tinea nigra is Hortea wernicki. It is a halophilic fungus, meaning that this particular fungus are usually located in those areas which are rich in salt, like along the seashores and beaches. This particular infection results from trauma from soil, sewage or wood also. The macule is because of the accumulation of the fungus which produce a melanin-like substance by feeding on the decomposed lipids in the skin. Lab diagnosis can be done by obtaining skin scrapings. KOH mount shows brown to black septate hyphae with budding yeast-like cells, and Sabrot's dextrose agar will give you greenish black colonies with a tar-like morphology with metallic sheen. Hortea wernicki is usually 2-cell yeast-like cell with dark transverse septa. It is also sometimes called as the black yeast. We again treat it with Whitfield's ointment, 5 to 10% salicylic acid or oral itraconazole. Usually, this self-limiting lesion resolves within 2 to 4 weeks of treatment. The next infection is pedra. Pedra in Spanish means stone. There are two types of pedra, white pedra and black pedra. In white pedra, you will find white grayish nodules on the hair shaft, primarily in facial, axillary, beard, and pubic hairs, along with itching. Whereas in black pedra, you find stone hard black nodules primarily in the scalp and the patient typically complains of a metallic sound heard while combing his hair. However, itching is not present in black pedra. In white pedra, the nodules can be easily detached and compared to black pedra, and the nodules are firmly attached to the hair shaft. The hair cuticle destruction is much lesser in white pedra when compared to that of the black pedra. Usually, the white pedra results from bad personal hygiene or swimming in stagnant water, more commonly associated with the female gender, whereas black pedra is more commonly seen in the males. However, having said that, generally there is no any gender predilection for in both these infections. White pedra is caused by the Trichosporon species and black pedra is caused by Pedria horte. Trichosporon species appear as cream-colored wrinkled colonies on Sabrod's dextrosagar, and black pedra, Pedria horte, appears as black cerebriform colonies with heaped up center and flat periphery. On microscopy, we can note the septate hyphae with arthrospores in Trichosporon species and dark septate hyphae asci with ascospores in Pedria horte. The only treatment for this condition is to shave the hair in the affected part. Again, topical azole shampoo and oral azoles are recommended with emphasis on good personal hygiene. Dermatophytosis, in fact, occupies a major component of the superficial fungal infection. This is also one of the most frequent occurrences in your routine clinical practice. Most of the dermatology OP clinics will definitely have one or two patients, if not more, of dermatophytosis. Dermatophytes is called a skin plant in literal parlance. These are keratinophilic fungi, meaning that they have affinity for skin, hair, and nails. The species of dermatophytes are Trichophyton, Epidermophyton, and Microsporum. Trichophyton affects all the three tissues, whereas Microsporum affects only the skin and hair, and Epidermophyton affects the skin and nail. Depending on their habitat, they can be classified as anthropophilic, geophilic, and zoophilic. Anthropophilic dermatophytes exclusively infect the humans, zoophilic infect animals and birds, and geophilic usually associated in the soil. These dermatophytes are luxury fungi in the sense that if you look at the colonies, they usually have a cottony, powdery, or velvety appearance. I just use the word luxury just for easy understanding. There are three different species, as I mentioned, and Before we proceed to the identification of the species, one common thing that we need to understand is that all these species are identified on the basis of asexual propagules or conidia. Depending on the size, you have macroconidia or big conidia or microconidia or small conidia. The proportion of macro and the microconidia enables the species or the genera differentiation, I should say. And the shape of the macroconidia further will enable the differentiation between the different species. If you look at Trichophyton, there are abundant teardrop shaped microconidia and scanty macroconidia. So whenever there is an abundant microconidia under the lactophenol cotton blue tease mount, always we have to turn our attention towards identifying the different species under the genera Trichophyton. Sometimes these abundant teardrop microconidia are also called as bird on wire appearance. There are several species of Trichophyton, but for your primary understanding, we need to remember that few very important species. Trichophyton rubrum is so called because it produces a red pigment on Sabrode's dextrosagar. It produces pencil-shaped macroconidia. The picture that you see here is of Trichophyton mentagrophytes, which gives a cigar-shaped macroconidia. Trichophyton seanleyni will have a favic chandelier appearance, and Trichophyton yonde or sodansis I mentioned only because of the fact that primarily it was thought that it was localized to West African countries, but it has been recently recovered by Hemshettar and colleagues in Karnataka. The next species, Microsporon, is predominantly identified by the fact that it has got an abundant macroconidia and scanty microconidia, just opposite to that of Trichophyton. So I repeat once again, in Trichophyton, microconidia is more than macroconidia, whereas in Microsporum, macroconidia is more than the microconidia. Again, you have principally three main species, Odoni, Canis and Gypsium. Odoni is anthropophilic, Canis zoophilic, and Microsporum gypsium is geophilic. However, according to the recent phylogenetic classification, Microsporum gypsium has been reclassified or renamed as Nanecia gypsia. This is just for your understanding. As you can see in this picture very clearly, you can find abundant boat-shaped or spindle-shaped macroconidia. In Microsporum canis, there are a lot of spines over the wall of the macroconidia, and they are almost truncated when compared to that of Microsporum odoni. This is the colony appearance of Microsporon. There is not much of a difference other than the fact that they appear velvety and whitish in nature. Then we have the other species, Epidermophyton. In contrast to Trichophyton and Microsporum, which has got 24 and 16 species each, Epidermophyton genera has got only one species, which is called as Epidermophyton flocosum. It produces, as you can see, khaki colored colonies or dark brown colored colonies, and there is no microconidia but pear or club shaped macroconidia. So whenever we see pear or club shaped macroconidia without any microconidia, definitely it is Epidermophyton species. Having said that, please also remember that there are certain dermatophytes which do not produce micro or macroconidia. As this is beyond the scope of discussion of the present lecture for your level, that is for the MBBS level, I am not delving more into details, but it is worthwhile to note that currently there are more and more genera of dermatophytes that have been identified. The newer genera are Arthroderma, Nanesia, Lobophyton and Paraphyton. Most of the species of Microsporon have been reclassified into these new genera. So, as I mentioned that this particular species are primarily keratinophilic, how do they cause these infection? The characteristic hallmark lesion is that dermatophytes causes serpentine, circular and annular ring-like lesions. It is because of the appearance of these lesions that these infections were previously called as tinea or ring-like, or they were attributed to a parasite ringworm. But now we know that this is not so. So what actually happens? Why do these annular skin lesions occur? This primarily occurs because of the proteases present in these dermatophytes, which destroy the keratinaceous tissues. The metabolic byproducts of these tissues diffuse through the Malpighian layer of the epidermis. The old hyphae that are formed in the center gradually break to form the arthrospores, and gradually there is a clearing of the lesions in the center. Therefore, while collecting the samples, it is very important to note that we need to collect the sample from the periphery of the lesion where there is actively multiplying arthrospores rather than from the center. Having said that, again, lot of changes in the clinical manifestation of dermatophytes have taken place presently, and in the current setup with more and more over the counter steroid combination drugs available for treatment of these lesions, we can even recover the dermatophytes from the central part of the lesion as well. Depending on the site of localization of the lesion, these dermatophytes have been given various names. If it is noticed in the scalp, it is called as Tinea capitis. The causative organisms of Tinea capitis are mentioned. Tinea capitis primarily causes many manifestations. Among them are chirion, which is you note a boggy scalp swelling with chronic pus and sinus formation, and favus, where there are chronic dense crust called scutula present around inflamed follicles. Favus is primarily caused by Trichophyton schonleni. There may be patchy alopecia with broken hair. If the infection occurs on the non-hairy skin of the body, extension from the groin, they are also called as Tinea corporis. The most common agent of Tinea corporis in India is Trichophyton rubrum. However, Trichophyton mentagrophytes infections have also been noted. Then among the wrestlers, especially in those areas which involve frequent hand to skin contact among the wrestlers, you will notice these tinea infections, and therefore it is called Tinea gladiatorum. Tinea gladiatorum is usually associated with Trichophyton tonsurans. Then you have barber's itch, where you find annular lesions over the bearded area of the face called as Tinea barbae. Due to the wearing of tight-fitting undergarments, annular lesions occurring in the groin can also be a possibility when it is called as Trichophyton cruris. If it occurs in the fingers, it is called Trichophyton manum. You can see whitish flakes. If it is present on the outer shaft, it is ectothrix. If it invades the hair shaft, it is called as endothrix infection. So, to diagnose, if it is seen in the feet, it is called as tinea pedis. Sorry, I did not mention that. And if it is seen in the nails, it is called tinea unguum. In tinea pedis, you find a classic appearance called as the moccasin feet. Okay, so how do we diagnose this infection? This infection can be diagnosed on the basis of a simple test which is called as the Woods lamp test. Now, Woods lamp testing examination can be done in a dark room, okay, where you will note that certain dermatophytes will fluoresce when they are viewed under the lamp. Usually it is positive for Microsporum and Trichophyton schonleini. Other dermatophytes like Malassezia furfur will also fluoresce yellow with Woods lamp. Now, even though the fluorescence is mainly because of the presence of the pigmentation in the cell wall of the dermatophytes. Okay, so Woods lamp is just a OP based examination. You can also do various laboratory diagnostic procedures for which we need to collect samples, hair, skin and nail obviously. Please note that the skins should be scraped properly and abundant skin scales must be obtained, and they must be transported preferably in a black paper for the simple reason that we can visualize these skin scales. Similarly, hairs should be plucked, it should not be cut, because we may miss ecto or endothrix infection which primarily affects the hair shaft. Nail clippings must be taken with utmost precautions after examining the lesions in the nail. Depending on the site of the lesions, whether proximal or distal or lateral, we may have to choose those appropriate areas to take the clippings with some amount of keratinaceous debris below the nail plate as well. So, we can, after we collect these samples, we can subject it to the examination. We have to culture with your dermatophyte test medium, which is a specialized medium, or we can also culture in the Sabarot's dextrose agar to get the characteristic morphological appearance and also the microscopic appearance, which we have previously described for all the three species separately. Hair perforation test and urease test can be additionally done to identify Trichophyton mentogrophytes. When we take the hairs for hair perforation test, we should ensure that this is taken only from a very young baby, okay, very young infant, to avoid the hormonal influences. So you inoculate a colony over this hair in a petri dish containing water and yeast extract, and if the mentogrophytes is present, we can see the piercing of this fungi producing wedge-shaped perforations. Additionally, we can also do a molecular testing. One thing that you should also remember is what is called as the dermatophytid or the EAD reaction. This is a hypersensitivity reaction occurring to the dermatophyte antigens, leading to the appearance of secondary eruptions in the sensitized patients. So, how do we treat this infection? We generally give oral terbinafine or itraconazole, but because of the increased development of resistance to this terbinafine, we can also opt for oral griseofulvin, and we can give topical Whitfield ointment or tonal fade in addition to all this. And itraconazole can be given for 6 weeks for skin, 6 to 12 weeks for hair and nails. Among all these 3 species, it is very difficult to eradicate the infection from the nails because of the protective nail plate, sequestration of the fungal elements between the nail bed and the nail plate, slowly growing nail, and also the poor penetration or poor efficacy of these antifungals. So, my dear friends, this completes the lecture on superficial mycosis and dermatophytosis. Hope that it has been useful to you. Thank you.